It's my pleasure to be here and moderate this session, the Haag-Streit Eyestar. I have been one of the first in Italy to test this machine 1 year ago. I was immediately surprised by the technology behind it, showing excellent repeatability of all measurements, new measurements that are available and that are not available on the competitors. And this machine, on one side, is the last one that has been introduced in the market, and as it often occurs with the latest developments, is at the top of the market in this moment. It has several features that make it impressive. How easy it is to use for the technician. It is almost totally automatic, and it has several advantages. So we took this unique opportunity to share the experience of such an advanced technology with some of the leaders in this field around the world. And we will be together with Dr. Goldblum from Switzerland, Warren Hill from Arizona, Dr. Sorkin from Tel Aviv, Dr. Le Quoy from Paris. And I kindly ask you to share your opinion and your experience with this technology.
Thank you very much for the kind introduction and also the kind invitation. I have a demanding case which I want to present you, because last year I've shown you a case where we looked at the biometry and the possibilities of this biometer. And this year I'm going to show you a case where we actually look at the imaging, what this device can do. So, and in the extreme cases, you always can see if a device is actually performing, how it is performing. This is a now 68-year-old man. He was referred to me in 2019, and it's a difficult case. So he was roughly 62 years old at the time. He's got on his right eye no light perception. This is the right eye, which had been blind for many years. I haven't seen him, so I met him first time in 2019. In ancient history, they say it's glaucomatous, it might be herpetic, he might have an anterior chamber in that eye. Anyway, this is a lost eye. The other eye he was referred to had a corneal decompensation in his left eye, and actually multiple glaucoma surgeries. In the case, it was written that he had a map dot fingerprint tryptophy, which I didn't see at that time. It was a decompensated cornea. So what I did, 2019, I actually did a DSEK for the first time for his endothelial replacement. And for almost 3 years, it went well. And 3 years later, it started to decompensate again. So what did I do? Obviously, after 3 years, I tried a second DSEK. And within roughly 1 year, it failed again, or started to fail. So this is actually the images of his second DSEK. You see endothelial decompensation already. Visual acuity went down to counting fingers, hand motion. And what can you do? What will you do now? There's several options in these demanding cases, and I wrote them down here. What I have to say is his IOP, he had multiple traps, failed again. He was in his 40s. He was on the complete IOP medication and systemic medication, and still the IOP was uncontrollable. I think that was maybe one of the reasons, again, why the second DSEK failed so quickly. And so who would dare to do a third DSEK? Who would go for penetrating keratoplasty or keratoprosthesis, minimal invasive glaucoma surgeries, retrap, valve, cyclophotocoagulation? There's no right or wrong, I think. What we did is my colleague who does a lot of XENs, he tried to do a minimally invasive glaucoma surgery, put in a XEN, which quickly failed again, unfortunately. Pressure went up again. So I did an Ahmed valve. I put it in, and this luckily worked. And third, to restore vision, I did a Boston keratoprosthesis. Since at the same time, by chance, we have a parallel session on Boston keratoprosthesis, I allowed myself to quickly show you the video of this case. It's 10 times accelerated. If you say you know what a Boston is and you know how it is done, then we can skip it. You use a normal donor keratoconus cornea, prepare it, put in the stem, the titanium backplate, lock it in. The backplate is about 8.5 millimeters in diameter, and then actually it works like a regular cornea transplant. You always can see that actually this is always, cannot hide it, this is always the same case because of this little hemangioma. I put in a Fleuringer ring for safety. This is a monocular patient, and I don't want to have an expulsive bleeding. Fleuringer rings actually, as I think of them, they should be attached somewhere, so I put them on the speculum and hook them up, or I even go through the skin. Trephination, and with best Boston keratoprosthesis, it's a regular transplant then. That's what it looks like. And you can see old iridectomies from failed traps. Actually, what you cannot see is the arachnoid valve is up here. I have to be careful not to cut it while preparing. And then this is the Boston. Just put it in, sutured in. You see that a lot of vascularization as well in this case, in this patient. And that's it. You stitch it in. It's a large diameter transplant. That's what it looked like at the end. So very luckily, this patient did very well with that prosthesis. His corrected distance visual acuity came up to 0.3, even near vision, which with magnification became 0.8. So he hasn't seen that well for many, many years. And it stayed that way. Now we're almost 1.5 years in to this transplant, so he kept his vision. I do histopathology in all these cases. That's the explant. You can see actually this is a retrocorneal membrane, and that's probably the reason why this P case failed or DSEX failed, and it would have failed again, because if you have these membranes, you cannot strip them all. They will grow back and will actually lead to failures in any way of penetrating keratoplasty or endothelial keratoplasty. But coming to the device I want to show you today, this is actually the imaging done with the Eyestar. And you can actually see this is the patient. He has got, this is the optical cylinder. You see the cornea, you see the iris, which is opposed here. You can tell there is a lens, vitreous. So this is, it's a bit coarse, but you can even, the contact lens on top of it, it's up here. You can see there's a contact lens on. Everything is visible in this imaging device, which is very useful and versatile if you use it. I want to show you the comparison. We have quite a park of devices. On the right hand, you have to see the CSO, the MS39. Below is the spectralis. We have an anterior, but we didn't put the patient in front of it. And on the top left, you see the Eyestar image. So it's very handy. The thing about it is that if you compare the whole image, and this is what I'm not showing you, or haven't shown you yet, on the Eyestar, you actually get a scan from top to back, no imaging no OCT of the retina, but as you can see, the MS39, which is a bit sharper, isn't going that far. And if you look further, his history said that he had an IOL on the iris. I didn't dare because it was not visible during the time of surgery. Actually, thanks to this device, I know now that the IOL is well in place. It's not attached to the iris because the iris is now attached to the cornea. It has gone further up. It might be sulcus fixated. I don't know. I haven't seen anything on the sclera. And even it stated that in his history he was vitrectomized. As you can tell, he's not vitrectomized because there is a lot of vitreous in that cavity in the posterior chamber. So thanks to the imaging of the Eyestar, there's a lot more information which I gathered thanks to that. Just for completeness, you see that's the image on the fundus through imaging with our other Haag-Streit device, so the 610. All images are taken by that on the slit lamp. So Just to complete Boston keratoprosthesis, you can see the patients need moxifloxacin or another fluoroquinolone and vancomycin and a contact lens for life, just to prevent infections and prevents meltings. That's also why one of the reasons I use an imaging device to see if there is early melts on the optic. There are other risks, as you can see, glaucoma, retroprosthetic membrane, which I'm afraid of in this patient. I've shown you the retrocorneal membrane. There's still a chance that something will overgrow this optic in the future. And don't neglect, don't forget, there's still an endophthalmitis risk even in these patients when they have lifelong antibiotics treatment. That's what it can look like. It's a patient which I didn't do the Boston, but was referred to me and ended up in an osteodontokeratoprosthesis. She then died a couple of years later due to a kidney cancer, but we saved that eye. If you want to know just the algorithm, how I do it, if you have a wet surface and little or no risk for regular transplants, you can do any penetrating keratoplasty, deep anterior or posterior endothelial keratoplasties. If you have a wet surface and a high risk of failure, retransplants mainly, or high pressure, I would recommend Boston keratoprosthesis. That's what I do. And if you have a dry surface, then as an osteodontokeratoprosthesis surgeon, I will put in a Strampelli or Temprano. And I have no experience with Boston type 2K pros, but these are possibilities as well. Thank you for your attention.
Okay, well, I'm going to talk a little bit about the topography features of the Eyestar. And what we're going to do is marry the Zernike pyramid and the aberration profile. I know whenever you hear the word Zernike, you want to leave the room, but actually it's probably one of the more valuable things we can have. And the great thing about the Eyestar is that everything is fully automated. This is a biometer that's been completely reimagined, and it has 3 different types of equipment in it. And it replaces 3 different devices. So it's like a room full of equipment in a single box. There's no compromises to any of the instrumentation that it displays. So it's not a biometer trying to be a topographer. It is one of the best topographers you'll ever use. And everything, as you would expect from Haag-Streit, is very, very sophisticated. And with this, we have better information, so we have better decision making. And one of the wonderful things about this device is it's fully automated. So staff members with really minimal skills or staff members who are your best people all get the same quality measurements. So that's really something. So just quickly to review, it's a type A topographer, just like the topographer you have taking up space in your diagnostic room. We measure the anterior and the posterior cornea very nicely, and we can generate maps of both of those, and we can also do pachymetry, which is very important when we start getting into ectatic diseases. So it's basically one of the best topographers you'll ever see, and again, it's really no compromise at all. And just to reiterate, the resolution is really quite stunning, and I'll show you some pictures of that. Again, it will do a Zernike analysis. This is one of the more valuable things that we feel the machine has to offer, and it's the center point for discussions, and I'll show you how to have that discussion with your patients. We do image simulations with it, and we have a large LED display in the room, and we show them how they're going to see after surgery. This is especially important after refractive surgery. And again, it has world-class keratometry. I'm going to mention just a few things about that in just a moment. But the marriage of the Zernike analysis and this image simulations has the potential to be one of the most valuable features of this machine and your discussions with patients. Now, we do the scanning just a little bit differently. So it does something called Mandela scanning, and typically with OCT, you're used to radial scannings, just one scan after another. This is how the anterior segment is scanned with the Eyestar. And you can see the density of the information that's obtained is significantly greater than just typical radial scans. So not only is this used for the cornea, but it's also used for the anterior segment. Unfortunately, we're not going to have time to go into the anterior segment imaging with this, but you can see how much more information is generated. With this, because the information is so dense, we can do motion compensation, we can generate just amazing topographic images, and again, we can image the anterior segment, as Dr. Goldblum says. So it's really 3 devices. You know, it's a biometer, it's a topographer, and it's an anterior segment OCT. So this little device that sits in the corner of a room takes the place of pretty much a whole room full of equipment. This is the advantage of motion compensation. Because we have such high density imaging, we can actually get rid of issues that maybe have to do with little saccades of the eye during the measurement process. And by the way, the whole measurement process for both eyes is 40 seconds. So it doesn't take up a lot of time. These are the 4 general maps that it does, and I've been asked to kind of explain what they are. This is an axial curvature map, which we're all very familiar with. Anterior elevation, which is a best fit sphere map, torical elevation, which is a best fit toric map, and then a tangential curvature, which I like for things like keratoconus and problems with where the power distribution is irregular or localized in some specific places. So let's talk about each one of these, and then I'm going to show you some examples of how we use this. And these 4 images are from the same eye of the same patient. So it shows you how different they can be. So we'll start with an axial curvature map. This is what most of us use in the practice of ophthalmology, and it's the preferred map pretty much for everybody. It displays the average of scaled values with smoothing, and it relates corneal shape to corneal power, and we can often use it to characterize astigmatism. Is astigmatism regular? Is it symmetrical? And what type is it? Is it with the rule, against the rule, etc.? The highest accuracy with this is near the center of the cornea, just because of the way the topographic map is generated. But this is what most of us use when we look at eyes for anterior segment surgery. Now, a best fit sphere elevation is a map where we fit the cornea against a spherical model, and it's often used when people do sophisticated contact lens fitting. So if you have an optometrist in your office that does contact lens fitting, you know, this is very useful. And so the red and orange areas are above the best fit sphere. The blue and green areas are below the best fit sphere. And this is a standard feature for all topographers. And this is just a schematic representation of mathematically, you know, how that is done. Best fit toric elevation is pretty much the same exercise, except we're using a best fit toric model. And again, the red and orange areas are above the best fit toric model. The blue and dark green areas are below. And it just shows elevation differences that cannot be accounted for with a best fit toric. Again, a standard feature of all topographers. So if you have a regular topographer and you bring up the different screens, this will be one of those. And lastly, a tangential curvature map measures points at a 9-degree tangent to the surface. And I like this when we have irregular areas of the cornea like keratoconus. And the images are, the areas are a little bit smaller, they're represented smaller, and it's really good at showing unusual areas. It's very, very sensitive to local irregularities. So the same picture we saw with an axial curvature map will be a little bit smaller with this. And again, I like this for unusual corneas. And it has less data smoothing. So these are the 4 basic maps that the Eyestar has, which are the same as your regular topographer. Again, it's not a biometer trying to be a topographer. It's one of the best topographers you've ever used. We can't talk about topography without also mentioning keratometry, and this is world-class keratometry. Those of you who have a Lenstar, you know, have grown to just love the way the Ks are presented. And so it's a dual zone keratometry. There are a couple little changes that have been made. The LEDs have been interdigitated to do a little bit better coverage. It has telecentric optics, which means if the patient's a little bit closer or a little bit farther away, it's distance independent, so it's still accurate. And the nice thing is that the Ks are the same as the Lenstar, so if you've optimized lens constants for that device, you don't have to make any changes. So the Ks are equivalent. There's no modifications required. So this is what the measurements look like. And again, those of you that have a Lenstar are used to the 2 rings being in the same meridian. Here they're interdigitated, and it's the same 1.65 and 2.3 millimeter rings. The Ks are very robust, and we can do eyes with the Eyestar that you can't do with almost any other device. Some of the LEDs are infrared, some of them are colored, and it's used for registration, so it does a very, very good job. And just one measurement's required for all of this to take place. And in that 40 seconds, all of this happens. And you notice at the bottom of the image, you'll see a little check mark next to topography and keratometry. And the machine has validation criteria running in the background. So you won't see a check mark unless the measurements are valid. Normally, we're used to having a little card with the validation criteria. It does all of that for you. So here's a patient who had radial keratotomy. We see a lot of radial keratotomy in my part of the United States. IOLMaster couldn't get any Ks whatsoever. Cornea was very distorted, and the patient has 11 diopters of astigmatism. Here's the LensStar, and this is a big surprise for us. The LensStar couldn't get any measurements on this eye. So sometimes these RK eyes are very, very flat and very distorted and have a huge power difference. With the Eyestar, we got an axial curvature map, we got validated Ks, and we got some diagnostic information. By the way, the Gould-Strand ratio is elevated like we see with RK, and the patient has an unstable ocular surface. So talk about, robust Ks and a wonderful topographic map. We can do things with this that we can't do with almost any other device. And in ours as a referral practice, we see a lot of unusual corneas like Dr. Goldblum, and for us, this works very, very nicely. This is what we use for toric planning. We'd use a lot of toric lenses. And basically, you can see a video keratographic image of how the LEDs are being used to generate the Ks. And it'll give you an axial curvature map. And from that axial curvature map, you can get the basic information required for a toric IOL. Is it regular, which means you can draw a line through the corneal vertex and the two astigmatic lobes? Is the astigmatism symmetrical, equal or similar power on either side of the corneal vertex? What's the orientation of the steep meridian? It will find it for you and display it for you. And what's the power difference between meridians, the basic astigmatism we're looking to correct? And then also, are the measurements valid? So when you see the little check mark next to where it says topography and keratometry, it means that all the validation criteria that run in the background have been met. So these are valid measurements, and the machine does the validation for you. That's got to be worth a lot, I think. So let's talk a little bit about how higher-order aberrations affect visual quality. This is normal image contrast in perhaps somebody that's had prior refractive surgery. All of the Zernike coefficients decrease contrast, and each one of them does it in a very specific way. And it's a nice discussion to have with someone if they come in to have cataract surgery after refractive surgery. So this is somebody that's had myopic LASIK, and you can see they have a central ablation. This is about 8 diopters. And if you look very closely at this, you can see that the ablation is actually a little bit off-center. Not only that, but there's a flat area that's even more off-center. So the flat area in the center will give us spherical aberration that causes a characteristic halo or glow around the image. And all of your patients have myopic LASIK. If they look at a point source of light, they'll describe this to you. And we have 1 micron of spherical aberration. That's almost 5 times the normal value. You can see the halo or glow around the big E. And because things are off-center, we also get coma, which is a form of irregular astigmatism, and that gives us image displacement and duplication. Horizontal coma will shift it to the right or the left, vertical coma up or down. Here's a patient for a toric IOL, very nice, regular symmetrical astigmatism, and we can show the patient what their vision's like with photopic, mesopic, and scotopic pupils compared to having the toric lens. This is the screen that we use, and we have the Zernike display here, the image simulation, then an axial curvature map, and we can check or uncheck different Zernike coefficients and show them what it would be like with the toric lens, or uncheck them all, show what it would be like with a contact lens. Same discussion again with myopic LASIK, photopic, mesopic, scotopic vision. All of the aberrations are increased as the pupil size goes up compared to a scleral contact lens. So we can show them what their vision will be like after surgery. Here's hyperopic LASIK. This looks a little bit like irregular astigmatism. And at a mesopic pupil size, we're going to recruit other areas, and it's going to contribute to the degradation of contrast. And the scotopic vision, it will be worse. This might be a candidate for something like the Contura, where you do topographic guided LASIK. And here's radial keratotomy, and this poor, unfortunate patient has a very flat cornea and lots of coma, and just a chaotic image. And there's no way to fix this except for a scleral contact lens. We're going to talk a little bit about the ectasia display, which we see a fair amount of keratoconus patients. And one question is, somebody comes in with this picture of the two kissing doves. Is this pellucid marginal degeneration? Oftentimes, we don't get enough imaging down below to be able to find that little band of thinning. And here it looks like it might not be, because the lower part looks normal, and then when you image the posterior cornea, this is just plain keratoconus. And pellucid marginal degeneration is really pretty uncommon. You might see maybe in a 40-year practice, maybe 10 of them. The machine will also do comparison maps, and we can track changes over time, and it will diagnose keratoconus for us. It will give us the Balin-Ambrosia display and also the Michael Balin ABCD classification method, so that we can track keratoconus over time and look for progression. This is just a very brief overview of the topographic features, but this is really a wonderful machine that does a lot for the cornea in many different ways. So thank you.
Thank you for the kind invitation to speak today. So we've all seen the biometry technology advance over the past few years, from ultrasound to optical to swept-source OCT. And we already know that swept-source OCT technology is accurate, repeatable, and it's already been shown to be more robust in eyes with media opacities, with an emphasis on eyes with more advanced cataract. So in the age of refractive cataract surgery, these advancements help us improve our IOL prediction. The Eyestar 900 is naturally a swept-source OCT device. It has several built-in features, and in this talk I'd like to share with you my favorite features, as well as show you our most recent data on the real-life accuracy of the device. My favorite features fall into three categories: the ergonomics, the built-in imaging, and the advanced IOL calculation. In ergonomics, and Dr. Hill mentioned that already, the acquisition is quite fast. It's a one-click, fully automated acquisition. It takes 40 seconds for the device not only to obtain everything, but also to produce all the outputs, and I'll detail some of those in a moment. And this, of course, gives us improved patient comfort, cooperation, and then our measurement quality increases. Another feature I like is this light chin-down positioning that our patients are at with the Eyestar. And this is more comfortable for the elderly and also patients with spinal issues. Our techs naturally love it because it's a one-click and it improves our workflow. As you can see in the video, by the time it took me to present this slide, the Eyestar finished acquiring all the images in both eyes of the patient. The second ergonomic feature that I like is, of course, the remote access. Our hospital is not small. The clinic is on the first floor where the Eyestar is. Then on the 11th floor, we have 3 ORs. And then we have another 2 ORs underground. Now, it's not uncommon that we need to make changes to the biometry if we only have the printout and the patient decides to change their preference a moment before surgery. We may have a problem. We also want to sometimes tweak our IOL parameters, change the SIA if it's a different surgeon, and that would have required me to run around the hospital back and forth, which is virtually impossible on a surgical day. So thank God we have the iSuite, and then we can access actually the the Eyestar from anywhere in the hospital, whether it's the clinic, the OR, or even at home with a VPN. As you can see here in the video, the surgeon can easily change the target refraction from plano to -2.5, and then you get immediate calculations in the OR. The built-in imaging includes, as mentioned by Dr. Hill, a full tomography suite that allows me to precisely evaluate our patients for premium IOL candidacy, as well as I'm also a cornea surgeon, so we can screen for any surface irregularities, things that can affect the outcome. Also, we have a difference map that can be provided by the machine. We can compare maps of different time points. Not only anterior axial curvature maps, actually the device can provide any type of map that you like. And also you can do a progression analysis on any parameter. For example, I'm a cornea surgeon. You can do a K-max progression analysis over a long period of time. I'm very excited to start using the ectasia display. It's just been introduced to our device. It's of course going to add the option of monitoring ectasia patients, also screening for ectasia. Dr. Hill described very nicely the Zernike analysis and the simulation of the quality of vision. We also, of course, have a full anterior chamber OCT imaging as shown by Dr. Goldblum, a detailed A-B scan, and IOL tilt analysis. And now looking at the advanced IOL calculation tools, we actually are getting a multi-formula printout, including several new generation formulas, including the Hill RBF, the Barrett and Olson predicted, as well as the Barrett and Olson measured, and the Weinkock adjustments for high myopia. I really like the IOL analysis as well as the printout, and I'll show you why. First of all, the device gives you a detailed analysis for each formula. For each formula, you get the IOL spherical equivalent, the toric power. For each formula, you get the implantation axis as well as the anticipated residual astigmatism. Now, on the left, that's the paper printout that I get when I do surgery, and then you can easily flip it over, and you have the data flipped over, and then you have a surgeon view, and it's actually including a real image of your patient so that you can confirm. And of course, it includes the implantation axis, the steep and flat meridians of the astigmatism, as well as the placement of the main incision. So we like the device, and we want to see how accurate it is in real life. We compared it with the IOLMaster 700 in 402 eyes, 402 patients, and we saw excellent agreement in all measurement variables. There was a slightly reduced agreement in corneal diameter measurements, but not expected to affect any outcome. The posterior keratometry also agreed very well between the devices. There was a constant difference between the devices, but that's just a result of the fact that the devices use an indirect measure of extrapolating the posterior cornea. Each does it a bit differently with different algorithms, but this, as you can see, did not affect the final outcome, as IOL power calculation using Barrett Universal showed excellent agreement. We predicted calculations, 98% of cases were within half a diopter, and with measured, it was 96% within half a diopter. Corneal astigmatism also showed very good agreement. Keratometric astigmatism in 95% of cases fell within half a diopter, and for posterior corneal astigmatism within an eighth of a diopter. This was also in correlation with Dr. Savini's group, who, as Dr. Savini mentioned, published a paper showing good measurement agreement between the Eyestar and the Eyestar. Our next step, naturally, was to see the real-life accuracy, the spherical equivalent prediction of the Eyestar. So we compared 225 eyes of 225 patients who underwent cataract surgery, and the post-operative outcome showed us that the prediction error distribution was practically similar, almost identical between the devices. This is actually using the new tool developed, the Itemis analysis tool, developed by Dr. Abulafia, Yuval Binyamini, and Yoav Kantor. And you can see that we're using Barrett Universal 2 for Eyestar predicted, Eyestar measured, IOLMaster predicted, IOLMaster measured. The results are similar. Now, when we look at absolute error, specifically looking at the threshold of half a diopter, so in all groups, approximately 9% of patients had an absolute error within half a diopter. When we compared the prediction error, we saw that the prediction error is similar between the devices. However, as a side effect of the comparison, this is not the main purpose of the study, we saw that predicted and measured calculations had a slight difference. Measured calculations using Barrett's formula were slightly deviating towards hyperopia, and this suggests that we may need a different A constant for measured calculations. Again, it's less relevant to our discussion, but it is an important finding. So to conclude, the Eyestar 900 is a robust swept-source OCT biometer. The important built-in features there help us a lot on our everyday life, and naturally we saw excellent IOL power prediction. Thank you.
Thank you for your kind invitation. Indication for IOL exchange are presented here. we are especially interesting with UGH syndrome, widely underestimated in our clinical practice. And the goal of this presentation is the visual discomfort after implantation. Visual discomfort means bad quality of vision, decrease of visual acuity, blurred vision, fog, glare, dysphotopsia, trouble of binocular vision, diplopia. Measure disability, measure distress for this patient. Visual discomfort can be due to IOL's incorrect positioning. Concern any type of IOL, mono or premium. This especially because of decentration, axis, intensity, and tilt. Inasmuch as greater is the pupillary diameter. The analysis is visual acuity far and near, pinhole, macular OCT, corneal topography and aberrometry, pupillar diameter, IOL positioning, tilt decentration, axial length. Case number 1. It's a 72-year-old patient operated on 3 years previously with multifocal implantation. Since 1 year, he has a foggy vision in both eyes. Visual acuity OD 2060 Jaeger 3, OS 2030 Jaeger 2. Under the operative microscope, we can see the decentration of this case, of this implant, multifocal implant. But, as you will see, there is, in association with the multifocal IOL, age-related maculopathy, with drusen, with irregularity of the pigmentary epithelium, but the retina seems flattened. OCT confirm the good shape of the retina, absence of neovascular membrane, but microperimetry show a decrease on visual sensitivity in the central part of the macula, as you see here, but no deep scotoma, and that permit us to ask the patient if he will accept to change the lens. The surgery starts with a sclerocorneal incision. Remove the lens and the capsular bag. We perform a complete vitrectomy with posterior vitreous detachment. We localize the fundus by transillumination, and we introduce the lens with 4 points of fixation. That, for us, it's very important to have a perfect stabilization of the IOL and good centration, and postoperative results is not so good because there is postoperative astigmatism, and we look at the the base scan high resolution. We saw the tilt that could explain the postoperative astigmatism of 3.5 dioptry. Internal astigmatism was of 2 diopters. We decided to remove the lens and to replace it correctly. Postoperative visual acuity was then 20/20. What gave us the strength to change the lens was the distress of the patient associated with the good image of the microperimetry. This eye should be worth better than 20/40. 3 months later, the patient came back saying, well, I am always in the fog. And we put it behind the OCT, and we saw macular edema treated and cured by injection of kinetolog. With 1 year later, the patient remained, the visual acuity remained 20/20, and the patient is out of the fog, and we are out of the wood. This is case number 2. A 53-year-old woman had LASIK in 2010 for myopia -4 and -5. No trouble up to 2018, then hollows due to cataract. Cataract extraction was done on both eyes with monovision. Visual acuity UD 2030 Jaeger 1. Visual acuity OS 2020 Jaeger 1. Vision of the right eye is blurred. She presented monocular diplopia and she complained about pain in the lower eyelid. We saw a shrinkage of the inferior part of the capsular bag, a shrinkage, and the implant was moved in the superior part. RMS is 0.500, and you see on the horizontal no problem, but on the vertical you see the dislocation, upper dislocation of the lens. Here a blowgun with irrigation probe, so the mark on the cornea. We remove the lens, and you see the adherence in the inferior part of the haptic, and then make probably a tension on the zonula. What was the cause of the pain at the level of the inferior eyelid? We decided to implant in the sulcus with a 3-piece IOL. First operatively, the result was good, with a recovery of visual acuity at 20/20, correction in both eyes. Case number 3. 72-year-old patient, no ocular history, cataract surgery with multifocal IOL in both eyes few months previously. Uneventful procedure. Capsulotomy has no effect. Tilt was 20.74, and there is a major decentration of this lens through a sclerocorneal incision with astigmatism free. And we introduced a new implant. First, we tried to put it in the bag in spite of capsulotomy, but for the reason of unstable IOL, we put it in the sulcus. The result postoperative is 20/20 with a similar astigmatism in both eyes. Postoperative data show that the scleral, the implantation on the left eye gives similar results as implantation in the right eye. Case number 4, 80-year-old patient, bilateral cataract operated on 2 years previously. Decrease of visual acuity of OS after laser, YAG laser. Probably the vision was not so good because they had to perform laser 1 year later. And the vision decreased geometrically after the laser YAG. As you see, the vision was 20/40 Jaeger 3. OS presented to the tilt not so much, 9.44 degree, and the decentration is rather soft, minus 0.69 millimeter. The length is 24.45. Remember the decentration up in the vertical axis minus 0.69. We remove the lens and we remove the summer-ring swollen capsular bag, and we decide not to implant in the sulcus. We decided to put a scleral fixated IOL with 3 point of fixation with Pronen 10O. We mark the sulcus at the point diametrically opposed by the apex of the cornea, and the fixation is, the centration is good. Postoperatively, the vision was 20/20, tilt 9.10, but no decentration. Conclusion. Imperfect IOL positioning, monofocal or multifocal, associated with macular problem or corneal aberration, can produce an amplification of the visual disorder. In this case, 1 + 1 no more equals 2, but 5. Providing the K data in a shorter time, as Eyestar 900 permits to do, help us to think about the true clinical situation to make the appropriate surgical indication. Thank you for your attention.
Is there any question from the audience? I have one question for Dr. Sorkin, because at the time I tested the Eyestar, posterior keratometry was not available in the early machines, and I did not make any comparison to the IOL Master, so I didn't follow very well your slide. So did you find that the measurements are closer to the IOL Master, which has a totally unique ratio between the anterior and posterior curvature, or it is closer, for example, to the Pentacam or other Shenfield machines that give a different value?
That's a good question. I didn't go into this, but actually, when we analyzed the data and we did the posterior to anterior radius ratio, we were surprised because in the IOL Master, the ratio is around 0.88, 0.9, which is higher than what we're used to. These are normal corneas. And indeed, the Eyestar did measure the average values that we're used to, and we saw throughout all the measurements, and we didn't figure out why until we understood that actually the IOL Master does a different measurement altogether, right?
The IOL Master is totally different, but this has some practical consequences, because when you go, for example, for post-LASIK calculations and you use the Barrett 2K with measured, you know that in the drop-down menu you have just two options. One is IOL Master and the other one is Pentacam, and this is due to the fact that they have very different posterior corneal radii. And I think that if you select IOL Master, you can only use IOL Master, but if you select Pentacam, you can enter the posterior curvature of any device measuring the posterior curvature, including the Eyestar. And this leads to a very important improvement of the Barrett 2K when when you pass from the predicted posterior corneal power to the measured posterior corneal power, the percentage of eyes with a prediction error within half a diopter, I'm talking about post-myopic LASIK, increases from around 50% to almost 70%. So having the posterior curvature for Barrett 2K is really helpful.
Actually, when we use the online calculator for measured calculations, and you have the IOL Master data, we don't input in the posterior cornea. We like to input the Pentacam posterior cornea. Then it's a good idea. Maybe here we can actually interchange. We need to check if we can interchange the Eyestar posterior cornea with the Pentacam.
It would be interesting to see. I don't think there should be any.
So we see a lot of patients with prior refractive surgery. And this ratio becomes important because it's what drives the calculation method. It's known as the Gould-Strand ratio. Let's say somebody is a low myope, and in one eye they had myopic LASIK, but in their near eye for monovision they had hyperopic LASIK to make them minus 250. So you're going to have two different calculation methods. So knowing what the Gould-Strand ratio is can help you. Also, a patient had LASIK and you say, what type of LASIK did you have? And they say, I don't know. So the first place we look at the Gould-Strand ratio to see what may be the calculation method. And if the Gould-Strand ratio is normal, they might have just had LASIK for mixed astigmatism, and you would do the calculation without using any special method. So this is a very important piece of information, knowing what's normal for one machine as compared to the other. And you're going to see some variation from one machine to the other, and usually it's either 88 or 83. 83 is most common for the Pentacam. 88 would be for the IOL Master, or perhaps the Anterior. So you need to know what the normal value is for that particular instrument.
I also have another question for everybody. What do you see in the next future for the IOL tilting measurement? Which is the importance? Everybody is talking about IOL tilting, but from a clinical point of view, there are some anecdotal reports, but no scientific study, at least with the Eyestar. But I think this will be the focus of a lot of clinical research in the next few years. Maybe with Adi Abulafia, you are already doing something. I don't know if you have any idea.
Well, we know that more is bad, and little is good. That we do know right now. And the numbers that people kind of banter around are like 6 to 7 degrees, are some numbers that people talk about. But it takes a lot of tilt to induce astigmatism. So exactly what are the cutoffs and what are the numbers? I think, as you've pointed out, we really don't know quite yet. So it needs to be studied.
I think actually I was thinking about it in the past couple of months, because we have a tool that's probably a robust tool that gives you an objective IOL tilt, and you can start looking for correlations between the lenticular astigmatism and the corneal and the total astigmatism, and this can have implications even for refractive surgery. So I would be interested in investigating it more. I think Adia Bolafia is doing some work in this matter, but there's a lot to be done. We're just starting.
And I would think if you do the biometry and someone has 6 or 7 or 8 degrees of tilt of their native crystalline lens, you might be circumspect about putting in a multifocal lens or some premium quality lens, because that tilt might be actually even amplified after surgery.
I think with this device, we enter in a new area of measurement. And I was dreaming about a formula to have a grade of the discomfort who has the patient. The formula including axial lens, tilt of the lens, diameter of the pupilla, astigmatism, and the score, to obtain a score, and listening at the patient. Compare with the score and decide the best solution.
Thank you, everybody, for participating, and for all the speakers for their valuable talks. Thank you very much.
The advantage of the device was that I actually couldn't see through that cloudy cornea and didn't know what was happening. Thanks to the imaging of the Eyestar, we could go and see actually deeper than what was possible with the normal slit lamp. The device is very easy for the workflow, so you can teach a technician and he or she will go, and it's a one-click device. It's very fast, it's very easy to use. What I like about Haag-Streit is that they are very, very helpful, and if you need anything in some special measurements out of the device, they will be quickly here and help you.
Well, we use the Eyestar to help explain to the patient how they're going to see after surgery, and that works with image simulation. We see a lot of patients with prior refractive surgery, and oftentimes these patients have abnormal aberration profiles. And if they come in after, say, myopic LASIK or radial keratotomy and are thinking about a multifocal lens, we can show them that probably would not be a good idea. If you show the patient before surgery and they have a problem, it's not your fault. If they discover it afterwards, then they're going to come looking for you. So it's always a good idea to give the patient an idea what their visual quality will be like after surgery. And that works for toric IOLs also. If you uncheck all the second-order aberrations like astigmatism and defocus, that's what the toric IOL corrects, and they can see the benefit of it. And so it's just a nice tool to help people understand what type of success they would have after surgery.
In the Eyestar, I specifically like the ergonomics. It's more comfortable for the patient to undergo biometry with the Eyestar. And since it's more comfortable for the patient, they cooperate better, and so we get better outcomes. Also, the device is designed so that patients with specific problems, such as elderly patients, or patients who have spine issues, for example, are more comfortable doing the exam, and we can see that it affects the outcomes. I like the fact that you actually receive more than one device in one click. I'm a cornea surgeon in addition to a cataract surgeon, and getting a full suite of tomography actually helps me diagnose and also screen for any corneal pathology that could affect my cataract outcomes, and I also can actually use the device as a cornea imaging device to replace any other device that I had before.
The Eyestar 900 is a major advance to appreciate, to evaluate the case in front of a patient. who had eventful cataract surgery. For example, we can evaluate the reason why, the source of the discomfort. The patient also, what is amazing situation with Zernike and simulation of the letter, E letter, that the patient is able to see. Once a patient told me, oh, it's the first time that a physician realized how dirty is my vision, because he saw the E, the glare, the foggy E on the screen of the device. That's very important, and it's a very new situation.
One of the questions I get is, how do I educate my patient about the outcome? And there the Eyestar provides you with a very handy tool, which is basically the Zernike analysis and vision simulation. So they can tell the patient where is the visual acuity lost, where is the contrast lost, and what can be done with an implant, where the limitations are. If a corneal surgeon approach me or a refractive surgeon, then their main topic is also how can I identify a corneal ecstatic patient, so somebody that might develop keratoconus in the future. And there we have a very nice corneal ectasia screen which combines all the information, maps, progression of the pachymetry and also the Berlin ABCD staging in one overview screen.